Good morning, and welcome to AFTD's 2021 Education Conference. I'm Susan Dickinson, Chief Executive Officer of AFTD, and I'm grateful to be spending this time with so many of you. This year, our conference looks and feels much different than it has in prior years. For so many of us, the past 15 months have brought new challenges, but the reasons we're here haven't changed. For people and families affected by FTD, this conference will offer the latest information and resources from experts in this field. Just as important, you'll have a chance to connect with others, to share your perspective and share hope for a future free of this disease. For those of you who are newly navigating an FTD diagnosis, we're glad you have found us. For those returning to join with us again, thank you for bringing your perspective, your insights, and your sense of community. I'd like to extend a special welcome to the health professionals and researchers joining us here today to find and share the latest information on care management and support strategies. We're thankful for your dedication to this community and the ways so many of you take this work so personally. This year's education conference is spread out across two 4-hour sessions, and we've designed our program to cover every aspect of FTD care and research that we can. We will highlight the work done by scientists, AFTD volunteers, and our staff over the past year. This virtual conference is the first of its kind for us. Usually, the AFTD Education Conference convenes several hundred people in a major American city for a full day of programming. But this year, more than 1,700 people from the US, Canada, and around the world have registered to join us, far more than ever before. Thank you to all who are here watching right now. I hope that next year we'll be able to join together with many of you in person. I hope you've had a chance to watch Dr. Peter Pressman's comprehensive breakdown of the FTD disorders. If not, I encourage you to watch it when you get the chance. Dr. Pressman is an assistant professor in cognitive and behavioral neurology at the University of Colorado, with a particular interest in FTD. No matter how much you know about FTD, I'm sure he'll teach you something new. I also want to point to the sponsors section of our aftdconference.org website, which you can access from the menu at the top of your screen. There you'll be able to see the gold, silver, and bronze sponsors who helped make this conference possible and free to all attendees. At this point, I'd like to introduce Bob Meddaugh, a member of AFTD's Persons with FTD Advisory Council. Bob has been living with the diagnosis of FTD for nearly 15 years. As co-chair of the council, Bob, his co-chair Teresa Webb, and all of our council members work to ensure that AFTD's work reflects and includes their vital perspective. Welcome, Bob, and on behalf of AFTD's staff and board, thank you.
Thank you, Susan. Welcome to the AFTD Education Conference for 2021. Over the years, this event has been so important to me and to my family. I've been living with behavior variant FTD diagnosis since 2007, although I did exhibit symptoms for a number of years before that. And I really can't imagine going through this journey without the resources, the information provided by FTD, and the connections I've made through the organization and meeting other people with FTD, like many of you in the audience. If this is your first time attending a conference, be prepared for a wealth of essential information about FTD, the science behind it, the lived experience of those with FTD, their caregivers, and the reason that you and I should be hopeful for a future free of FTD. Later today, I'll join the rest of the Persons with FTD Advisory Council for a special session where we'll discuss some of the most important aspects of our own FTD journeys. Inclusion, isolation, grief, and collaboration. We believe that AFTD's goals cannot truly be accomplished unless the voices of those diagnosed with FTD have a prominent say. We hope you will find this session compelling and persuasive. And then in the breakout session following that, we will be able to answer questions and explain it in more detail. Now I'll send it back to you, Susan.
Thank you, Bob. Over the next 2 days, you'll all have the opportunity to interact with this conference in a few different ways. One of those ways is through live polling. As the day goes forward, we'll share and reflect on the results of these polls. Your response to any of these questions will be anonymous. Let's get that started with the first question, where we'll ask people and families affected by FTD to share the specific diagnosis that brings you here with us today. And now, Sharon Denny, AFTD's Senior Director of Programs, will introduce our first session.
Thank you, Susan and Bob. Welcome again to our 2021 Education Conference. Sharon Denny, AFTD's Senior Director of Programs. I haven't yet had a chance to meet some of you, but with many others in the audience today, it feels like a long time since we've been able to be together in person. And while this doesn't quite feel like enough, it's good to be here with all of you today. I hope that through this conference, you'll find things to make your FTD journey less burdensome and that you experience valuable connections with others. Leading off our program is Tia Powell. Dr. Powell is a nationally renowned psychiatrist and bioethicist. She directs the Montefiore Einstein Center for Bioethics at the Albert Einstein College of Medicine in the Bronx. She's also the author of Dementia Reimagined. Time permitting, we'll have a short Q&A with Dr. Powell after her talk. To submit a question, type it into the Q&A tab that you see on your screen, and we'll answer as many as time allows. And now, Dr. Tia Powell.
Hello to the group. It's really quite an honor to be with you here today and to think with you about dementia care. I always acknowledge at the beginning of a talk like this that there are many of you, because of your lived experience, who have unbelievable expertise in just this issue. So I'll frame these comments today as thinking together about what work lies ahead so that we can really improve care and get for ourselves, our friends, our families, our communities, the care that we need and deserve. So just to think with you for a minute about, the notion of, at this point, improving dementia care. We are still not free from, by far, the worst public health crisis, certainly in the United States, but probably globally, in more than a century. This seems to be, in some ways, a terrible time to improve any aspect of the healthcare system. We're hanging on by our fingernails just to get the basics done. So we've seen that COVID shows an ugly mirror to many of the existing flaws in our current system. That was particularly true for people with dementia, people living in nursing homes. People with dementia, we know, are at the highest risk, and we saw that in the devastating mortality statistics for people with dementia during COVID. But even under ordinary times, our care is fragmented, it's too expensive, but also inadequate. And for many people, depending on where you live, choices are very, very limited. So this is quite a daunting task. How can we work toward care that we would really want? I often like to show this photograph. This was my mother when she was barely a teenager. I think she's 13 in there. And this is at her confirmation ceremony. My family was Catholic. There is, as we know, no cure today for dementia. I hope one day there will be useful treatments and maybe even cures. I personally don't think that day is coming very soon. That doesn't mean, however, that there can be no hope. I actually think the hope that we can have today is to really think about what it means to provide excellent care that's respectful, that's dignified, that helps people with dementia or who have family members with dementia really feel that this is a life that is a good life and that is well supported. So I have the privilege, I'm just finishing up work chairing a committee for the National Academy of Medicine. So this goes much more in the good news category. This committee is funded to kind of set out a 10-year research roadmap within the social sciences to support the lives of people living with dementia and their care partners. It is, unlike a lot of research, not focused on pharma, but focused on social science supports and interventions, long-term care, that kind of thing. Among our expert advisors as part of this committee were people living with dementias and with dementia and their caregivers. This should be the norm. It's been relatively rare in the US, but I'm happy to say is becoming more and more the norm. I think the UK and Europe has been substantially ahead of us here in really going out of their way to include people with lived experience in order to find out, well, what is needed? What do we need to do better? You should ask the people who know best. That report from the National Academy of Medicine will come out, I hope, in July, just a few months from now. I can't tell you what the report will say because it hasn't come out yet, but I am allowed to talk about some of the public information that was presented during the course of the report. There was some good news in what we found. One is that year by year, decade by decade, there is a better awareness of dementia, all the different types of dementia. Is it where it should be? No. And I think people in the FTD community know that better than anybody. But bit by bit, I think we are making progress because this is an issue in so many families, so many communities. There is better engagement with people with dementia and their caregivers. And there's good research and there's some solid interventions to provide better care around the country. Very importantly, there's also a real recognition of the impact of social determinants of health and the fact that ethnicity, race, income have an unfair and outsized impact on who gets dementia and what they can do about it. There are some interesting new approaches. A lot of people have written about the arts. Technology on this topic, which I won't focus on today, is booming. Some of it's probably going to turn out to be more useful than other things. There seems to be a new app popping up every day. But I actually do think that there's real room for benefit in technology to figure out how we can stretch farther the energies and the expertise of our caregivers. I think we can do a lot with networking. So that's in the good news. There are a lot of areas, as I said, this group is more than aware, where there's real room for improvement. Over and over again, the information that was presented to the committee focused on the problem with diagnosis. And I think this is particularly true in frontotemporal dementia. There are so many people with stories, and indeed, it's very hard to find somebody with FTD who can talk to you about a really successful experience with diagnosis. They knew right away, they did the right thing, I had the right information, I went to the right person. That is absolutely not the norm, and it should be the norm. We're thinking that there's much more to be done to support both people with dementia and their caregivers. And although there are some really interesting programs coming up around the country, much more needs to be done to integrate medical care so that the different specialists know what's going on. But also more than medical care, there's so much more. I won't be able to talk about all these issues in detail today, but there's a long list of things that need to be done better to really get us going in the right direction. I won't even say that we'll arrive with the care that we need, but moving forward toward it. So let's think for a minute about diagnosis. It really requires a lot of improvement in various different steps. Just recognizing the diverse symptoms is really difficult. The education of physicians and healthcare professionals is not at all what it should be. Everybody knows that there could be issues with memory loss, but for people with dementia who don't have memory loss as a prominent symptom, they're really in trouble. So, and of course, there are innumerable other symptoms. People with a profound affective presentation, with anxiety, with depression, even psychotic features, that's very commonly misdiagnosed. And yet these are common features of dementia. So we need to be able to do better than that. It's not a mystery, but the basic information about what constellation of symptoms can help you know that the person in front of you has a form of dementia and begin to figure out what type and what we can do about that. We don't do enough to refer to experts, but really, I'm actually in some ways more concerned with not doing enough to have the basic tools of recognizing dementia in the hands of everybody who sees patients. We also need to do a much better job of thinking about the broader sense of social services, finance, I'll come back to that later, but also housing, accessible housing, making someone who wants to stay in their home, how can you make that safe and appropriate? There's some great programs there, but they're not available to enough people. And work, particularly in FTD, there are people who do show symptoms and get the diagnosis who are still working. How do we handle that? How do we figure out what can be done to help people in that domain? Here's an example. I'm going to use some photographs during the presentation. None of those are real people. They are all, anonymous web photographs that are up for anybody to use. But it's helpful to me to remind us by using the photograph that we're talking very much about real people. The Mr. S, actually, this is not his photograph, but he's very much a real person. He was known to me through my larger extended family. He was 82 years old at the time I'm thinking of him. His symptoms were agitation, paranoia, and wildly out of context, domestic violence. He would, from time to time, become agitated and push, sometimes even to the floor. His older wife, who was herself somewhat frail, this was completely out of character. Mr. S had been, when I knew him at a younger age, incredibly funny, charming, sociable, really smart, very successful in his professional work. When he developed the symptoms of dementia, he became quite different than who he had been in health. And this, of course, was incredibly distressing to the rest of his family. They did send him to a geriatric psychiatrist, but amazingly, that person never made the diagnosis of dementia, or certainly did not share it with the family. After some years of these various different symptoms, he hit his head and there was concern about internal bleeding. So we ended up seeing a neurologist. And even then, after almost a year of care, the neurologist mentioned in passing something like, well, people with dementia do X, Y, and Z. That was the first time that Mrs. S heard the diagnosis of dementia. This is an affluent family with plenty of access to care, not very long ago. And though this was clearly a case of dementia, and certainly an older person with other comorbidities as well, it was unknown to them. And there was real harm in not giving them the diagnosis. I know there are even physicians who say, why bother? There's no treatment. I strongly disagree with that. This caused this family unbelievable confusion and grief. They had no idea why he was doing the things he was doing, some of which were really hurtful and destructive of his reputation within his family and the love that his family held for him. It also cost them a lot of money with care that was ineffective and inappropriate, and also sort of moving and getting help. It was really harmful to this family to go without diagnosis. Here's another de-identified case. Again, not the real photograph of this person, but again, a real person. A younger person when starting to get behavioral changes. Ms. C was a professional, had worked all her life and had a position of some responsibility, but started having trouble doing her job. The diagnosis was delayed as she was sort of shuttled from place to place, but she had a relative who was a physician who took her under his wing and organized care for her and a workup at a major medical center. They did everything, every test known to man, and correctly they made the diagnosis. And this is how it went. Ms. C and her relative went into the neurologist's office, and that person said, well, yes, you do have dementia. I'm really sorry. You should come back in 6 months. There's really no treatment that's worth anything. I can sign you up for research if you want. What they described that as, it was being hit by a bomb. There was no mention of support, no trying to help her articulate the million questions that came up for her. Should I quit my job? What will that mean in terms of benefits and insurance? Do I have to move? Am I capable of handling my money? When will I change? What else should I do? Who can I tell? Who can I not tell? This person at this physician at this major medical center was making a correct diagnosis, using the correct tools, and in that sense, satisfied the standard of care. What I'm saying is that the standard of care is wrong. that didn't satisfy the needs of this family. There was much more for them beyond just getting the diagnosis, though that's hard enough. They needed to be connected into a network of people, not exclusively physicians, who could help them along the way, who could respond to them as they tried to work their way through understanding an enormous change that they needed to sort through and respond to. The dementia workforce. This is a really important issue. And frankly, in the United States, we've done a pretty bad job at addressing the needs of what kind of workforce we need and what are the needs of the people who are in that workforce themselves. At every level of healthcare worker, the pay for people working on dementia is poor. At the same time, there is growing need. There are more and more people, not fewer, getting dementia. The shrinking numbers refers not to people with dementia, but to people in the dementia workforce. There have been efforts to try and fix this, but boy, we have a lot more work to do on this issue. Again, not a real photograph from that person, but let me think with you for a minute about who does provide direct care to people with dementia. This is Miss L. She is a minority woman, which is typical of people who provide care. They are primarily, indeed overwhelmingly, Black and brown women. Many are relatively recent immigrants. Until relatively recent, they did not qualify for minimum wage standards. Didn't even have to pay them the minimum wage that fast food workers have long been entitled to. So like a lot of direct care providers, Miss L worked 3 high-risk jobs. She worked in 2 separate skilled nursing facilities and also did home care work. In all those settings, the pay was low. She needed full-time work. She has a family to support, but she couldn't get a full-time job at any one place because that meant that they would have to pay her benefits. So she has no benefits, no sick leave. And even during COVID, people like Miss L were going from place to place, exposing themselves and the people they cared for and their families to risk of COVID. This is an enormous contributor to the number of nursing home deaths in the United States. There were nursing home issues in all countries, but this is part of how we did it in the US. Having somebody have to go from facility to facility and not be able to take sick leave off and get paid, that's a recipe for disaster, and disaster we got. Moreover, there was a global competition on the free market to buy protective equipment, and the major medical centers were doing their best to snap it up in China and all kinds of places. Particularly independent nursing homes had absolutely no capacity to buy protective equipment when it was at the most scarce. So there were quite serious limits of protective equipment in various nursing homes during the peak in COVID. I speak primarily from my experience in New York, which was pretty bad, but talking to some people working in nursing homes at that time, the lack of protective equipment was really shocking in the beginning. They got it later. But even the physicians who were taking care of people with dementia, as far as I know, a special fellowship in geriatrics is the only way in which a physician can reduce her expected income. In every other specialty, if you're an internist and you go on and add training and infectious disease or something else, you can expect to have a little bit more money because of your greater expertise. No, if you do geriatrics, we'll pay you less. This is a perfect way to prevent people from going into geriatrics. There have been some efforts to work on this, to sort of cover medical school loans, to sort of help with other issues, but we still have a big problem on this issue. We need expertise. The group is shrinking, and those who remain are aging in place. We have many fellowship opportunities that go unfilled because young physicians can't afford to take them. This is a terrible business plan. I've never even worked in a for-profit business. My whole career has been in the nonprofit side, working for nonprofit hospitals. But even I can recognize this is no way to do business. We need a better plan. If we want the best people, we want to attract them, and we want to retain them. I will point out, I'm going to talk quickly, but just give you a fast overview. Nursing homes. Nursing homes, even before COVID, were responsible for about 1/4 of the deaths in the US. We end up in nursing homes when we're nearing the end of life, if we're going to be long-term residents. So this is an incredibly vulnerable group. But during the COVID pandemic, oh my goodness, high-risk population, death was incredibly common because of lack of protective equipment, testing, inability to isolate cases and keep the disease from spreading, and because of challenges to getting enough people and protecting the workforce. But then we tried to help by isolating people living in nursing homes with dementia. And the majority of people who are long-term residents of nursing homes are people with dementia. There's a wonderful survey of nursing home residents done in 2020. And one of the quotes from one of the people in that survey was, "If COVID doesn't kill me, loneliness will." So we tried to keep COVID out, and in doing that, we exposed people living in our nursing homes to desperate degrees of loneliness, and they really bore the brunt. They bore a terrible impact from that. Again, I can't say what would have easily been better. It was a challenging situation, but we need a better response next time, because there can be a next time. So paying for dementia care, this is a huge issue, big expense. Families are providing care, they're losing wages, or they're paying for care. It's a financial strain. This is a huge strain on all aspects of generations of our families. And it is a problem that is heading like a meteor for the children of baby boomers. So what can we do? Here are a few ideas, small ideas for a big problem, but just to start our conversation and to think with this group about advocacy, let's think together. We need to say that the current standard of care is unacceptable. A diagnosis of dementia needs to immediately lead to handoff for social services to address with the person, what does this mean to you? How can we help you? Even if we don't have a cure, what's in place for you? How can you reach out to get resources that are there? We need to educate everybody in medicine better to recognize dementia and make that diagnosis so that this person and this family knows what's coming. We need to think about specialist referral and do all these other things. But what we really need to do is build a safety net. We're beginning to, but it is not where it should be. We have a lot of catch-up work to do. And it should feel like a safety net when you should feel a safety net when you get the diagnosis of dementia of any type. It should not feel like someone dropping a bomb on you. Medical care, I won't say more about today. I'm going to speed through these, but I also want to look at things that are not in medical care. There's $3 billion a year in the US of elder financial abuse. So much of it is done by people who know that person. We need to have protections for that. We need to figure out how you get disability, how we do a better job with housing that's flexible, that doesn't isolate people, that's safe, and how we integrate people with dementia into our communities, because loneliness is a terrible affliction and one that we should be able to address. And we need to pay at every level. We need to pay people better. Certainly, the minimum wage at least, but maybe even a living wage. And there need to be a career pathway, ways to move forward. We need to have ways to attract and retain the best people, because this work is important. So how do we pay for that? That's a whole, hour-long lecture. I'll just put up a few bullets for you. But I will say, this is really interesting. I don't want to play into the red-blue divide in our country, and I know people, this was such a contested election that we have, but if you are in the dementia community, you should look at the Biden infrastructure proposal. It has some really interesting things in there about caregiving, and I would say it's about time. It looks at pay raises for those people who provide direct care, getting them benefits, providing training, providing career ladders. The things that I think anybody who cares about better dementia care would want are in that proposal for infrastructure. For families, there are tax credits proposed, or Social Security credit. If you're giving up paid work in order to provide care, maybe that should count towards your Social Security. Better access to home care, ending Medicaid wait lists, which are almost 1 million people in the US, and bringing in about 150,000 community health workers. It is a really interesting proposal. I think for those of you who are interested in advocacy, you should look to this and see if there are things that align with what you think is right for your family and your community. So I'm a gardener, not a good gardener, but a dedicated one. And I said to you, this is the best and worst time to improve dementia care. Well, you've heard some things about why it's the worst time, COVID, but when is the best time? Well, I'll give you an adage from gardening. When is the best time to plant a tree? The first answer is 20 years ago. The second best time, though, to plant a tree is today. So I'm going to leave you with a more hopeful slide, and I will go from there. I think I'm over time, but if we have time for questions, I'm certainly happy to do that.
Thank you, Dr. Powell. You've really set the stage so beautifully and so broadly for a lot of the work that we're going to do together over the next couple of days. And I'm really grateful for that. I think we probably have time for maybe 1 or 2 questions. And I'd like to actually start by hearkening back to your book and the subtitle of your book, which I think also stems from just your overarching approach to what dementia care should look like. The subtitle of your book is Building a Life of Joy and Dignity from Beginning to End. And you had mentioned this in the beginning of your talk today. And, you know, we know that at each step along the way, the decisions that families have to make are really profoundly difficult and challenging because the services and the care options available are often not ideal, less than ideal, as you've been speaking to. I would just be interested to know, what guidance do you offer people at that individual level when they're trying to make care decisions based on their own values in a system and in a situation that's often very challenging?
That's such a great question. Thank you for that. I think this is one of the fundamental clinical and ethics challenges in getting good dementia care. With dementia, it becomes progressively harder for a person with dementia to communicate, to advocate for themselves, to represent what their views and values are. That doesn't mean they don't have those views and values and preferences. But I think the healthcare system, you know, it treats populations. It has a bunch of things that it can throw at a problem, but it may not know what's best for this individual person. And it is the role of the advocate. You're so lucky if you have dementia, if you have a family advocating for you. Not everyone has that. And I define family broadly to include other loved ones, unmarried partners, all the people who care about you. But it's up to that group to say, I understand that somebody might want this, but I know this person and I know what they told me. And for them, this is more important for that. So for some people, for religious reasons or other, they may want to live the greatest number of days possible, and they don't care if they're suffering. That is a choice that one might make. It is not the choice that most people with dementia make. Most people with dementia recognize that this, unfortunately, is a terminal illness. And in that context, whether it's cancer or something else, it's appropriate. And for many people, the value is on comfort, quality of life, spending time with the people that you like to spend time with, and not even the nicest healthcare professional is really anywhere near as good as being next to your family member. So, you know, you may say, listen, I know you're trying to help me, but we want less time in the hospital, fewer tests unless they're really going to change something, focus on comfort, focus on doing the things that this person loves to do. And that may just be sitting outside in a garden. Much better that than sitting inside in a day room at a center that they don't want to be at. So, you know, I think in healthcare, we focus on safety and, you know, that's all to the good. But I think it's time to make the individual with dementia an individual who has particular preferences that aren't the same as everyone. And I know, you know, acting on that and really pushing for it is something that I really salute advocates who focus on that and are able to get that done. I want to meet you there and help you be able to get that done.
Thank you so much. I've really appreciated, again, how you set the table for our conference for today. And I really appreciate you bringing your expertise into our meeting at this point. So that's all the time we have. We could spend more with you for sure. And I hope we have the opportunity again in the future. So thank you.
Sharon, thank you for all the work that you do.
Thanks.
Bye-bye.